Hello, this is the Almonds and Weight Management webinar brought to you by the Almond Board of California. Welcome to the webinar. My name is Swati Kalgaonkar and I'm Associate Director for Nutrition Research Program at the Almond Board of California. I have a PhD in nutritional science and an extensive nutrition clinical research experience. My primary focus is oversight of ABC contracted nutrition research, public policy analysis and synthesis, and information dissemination in support of the almond industry's global strategies. Before we get started with the webinar, there are a few housekeeping details to cover. During this webinar, all attendees will be muted. If at any time you have technical issues, please access the help screens at top of your attendee control panel. If you have questions, please type them into the Q&A box. We request that you do not type them in the chat box, and they will be answered at the end of the presentation. Speakers will be closed captioned and slides will be available to aid in review. The session will be recorded and available in 3 days' time for self-study. We hope you will follow us on social channels on Twitter, Instagram, and Facebook. Here's the agenda for today's webinar. We will be starting with an Almonds and Health review of the Almond Board funded research. We will then be introducing you to our speakers, who will be covering net consumption, appetite, and food intake, and we'll wrap up the session with a Q&A session afterwards. So to get us started, we have a polling question. On a scale of 1 to 5, with 1 being the lowest and 5 the highest, how would you rate your knowledge about almond research into appetite and metabolic response? Please answer in the polling panel. Almond Board Nutrition Research Program has been in existence for 25 years and has invested over $30 million towards almond nutrition research, with majority of that investment going towards robust clinical research. Over 130 projects have been funded in that duration, resulting in almost 200 publications that make us very proud. Almonds are a great food product and can be part of any healthy eating pattern because they provide hero nutrients like vitamin E, magnesium, healthy fats, fiber, and protein. And here's just an example of some of those dietary patterns that almonds fit into. National recommendations for net consumption vary somewhat from one country to another, but generally speaking, most countries recommend daily net consumption. Now, one of the most well-studied areas of almond nutrition research is that of heart health, and several studies have been conducted to investigate the role of almonds in heart health. Over the course of time, multiple studies in this area have generated a strong body of evidence in favor of almonds. This evidence, taken together with evidence from other nut studies, was used for a health claim application to FDA. And in 2003, FDA approved the following qualified health claim on the heart healthy impact of nuts. It reads, "Scientific evidence suggests, but does not prove, that eating 1.5 ounces per day of most nuts, such as almonds, as part of a diet low in saturated fat and cholesterol, may reduce the risk of heart disease." Now, systematic reviews and meta-analyses provide what is considered the highest level of evidence and allow researchers to draw meaningful conclusions from a comprehensive body of research. The results of this systematic review and meta-analysis established that consumption of 1.5 ounces, which is about 42 grams of almonds per day, not only help lower total and bad cholesterol levels alongside triglycerides, but also help maintain good cholesterol levels, a benefit that is rare to most heart-healthy foods. The key takeaway from this study is that almonds are a great food to incorporate in your diet if you're looking to help lower your total and bad cholesterol levels. This study by Rick Mattis and his study group demonstrated that almond consumption during a 12-week energy restriction reduced truncal fat and systolic blood pressure. A greater reduction in total fat, diastolic blood pressure, and a greater tendency for reduction in visceral adipose tissue was observed in the almond group compared to the nut-free diet group. It's important to note that in addition to demonstrating a reduction in upper body fat, which is a result consistent with other studies, this study also showed a reduction in systolic and diastolic blood pressure. The health of a blood vessel is important for healthy blood pressure, so it was imperative to investigate if almonds played a beneficial role in this area as well. A study conducted at King's College London by Sarah Berry and Wendy Hall investigated the role of almonds in improving flow-mediated dilation, or FMD, which is a marker of blood vessel health. The study found that almond consumption significantly improved FMD, in addition to the consistently observed reductions in cholesterol levels. As you know, the National Diet and Nutrition Survey, or NDNS, conducts a survey of diet quality and health parameters in the UK. In a recently published study, analysis of NDNS data demonstrated that whole almond consumption is associated with better diet quality and cardiovascular disease risk factors in the UK adult population. The next key research area of blood glucose management is equally important as it is closely related to heart health. Southeast Asian phenotype is the most challenging in terms of type 2 diabetes. This study, conducted in Asian Indians, demonstrated heart health benefits of almonds in type 2 diabetic patients. Results from these studies and across different populations has shown consistent results. 16 studies to date in a variety of subject populations and with different blood glucose related outcomes show that almonds help reduce insulin resistance and hemoglobin A1C. Now, India has the second highest number of diabetes patients aged 20 to 79 years. So several new studies are focused on the glucoregulatory health of the highly challenging Southeast Asian population. The studies are currently underway and the results are awaited. Now, this next research area of skin health is fairly new to almonds, but it is in line with cardiometabolic health effects observed based on the premise that our body is all one organism. The pilot or test study in this area was conducted to look at the impact of almond intake, which is consumption and not topical application, on wrinkles. The first picture on this slide shows the normal progression of skin wrinkles from youth to old age. We all experience water loss from skin surface, but as we age, the rate of this process tends to accelerate, as shown in the second picture, and that leads to further wrinkling of the skin. Now, Raja Sivamani's research group at UC Davis conducted this study in postmenopausal women with one of the more challenging skin types, which is Fitzpatrick skin type 1 or 2, that tends to burn and wrinkle easily from sun exposure. The subjects were divided into two groups, one that incorporated almonds as part of their diet at 20% energy intake for 4 months, and one that did not. Skin wrinkles were assessed by taking a very high-resolution picture of each subject's face using a 3D imaging equipment. And after 4 weeks of almond consumption, the images showed a significant reduction in skin wrinkles in women who consumed almonds versus those that did not. Both wrinkle width and wrinkle severity, which is a factor of wrinkle length and depth, were reduced significantly in the almond group. A follow-up study with longer study duration and more women subjects not only demonstrated similar results, but these results were sustained to the 24-week time point. This reproducibility of results proved data robustness. This study also investigated the effect of almond consumption on skin pigmentation, and results demonstrated that eating almonds significantly improved skin pigmentation towards a more even skin tone. Now, when it comes to sun damage, photoaging tops the list of skin health concerns. We know that UVB rays cause skin redness and burning and are responsible for photo damage. So Dr. Xiaoping Li from UCLA conducted a study in Fitzpatrick skin types 2 to 4 to better understand the role of almonds in protecting the skin from sun damage. The sunburn that one might get at a beach can also be induced in a controlled setting under medical supervision. In this study, that damage was measured, and it was found that almonds accorded protection from UVB-related photo damage. Subjects on almond treatment required greater UVB exposure to experience the same amount of damage as those on control food. With that, I'd like to introduce our speakers. So as I said earlier, we are joined today by 2 esteemed nutrition researchers. Dr. Richard Mattis is one of America's premier nutrition scientists. He is Distinguished Professor of Nutrition Science at Purdue University and former president of the American Society of Nutrition. Dr. Mattis also served on the 2020 Dietary Guidelines Advisory Committee and has authored over 285 publications. We're also joined by Dr. Stephanie Hunter. She is a postdoctoral fellow at Monell Chemical Senses Center. Dr. Hunter earned an undergraduate degree in cell and molecular biology from Winona State University, as well as a doctorate degree in nutrition science with an emphasis in ingestive behavior from Purdue University under the mentorship of Dr. Mattis.
So thank you, Swati, for that overly generous introduction, and we'll jump right in. As you said, the topic today is nut consumption, appetite, and food intake, with an emphasis on new insights. For those who follow this literature surrounding nut consumption and health effects, there are a number of findings that are now pretty well accepted. And to just summarize them quickly, the first is that consumption of nuts really has a neutral effect on body weight. That the inclusion of nuts either in a free living diet or even in a diet that is energy restricted does not lead to positive energy balance or disruption of the therapeutic goal of the diet. Second, that consumption of nuts positively impacts diet quality as measured by the Healthy Eating Index. Third, that consumption of nuts may enhance diet palatability and as a result resist monotony effects. That is, that people find them palatable and are willing to consume them on a regular basis. And finally, that there may be a special role of nut consumption in the reduction of truncal fat, and this is the fat depots. These are the fat depots that are most closely associated with metabolic health, so of particular interest here. So, as I said, those who are really closely watching the literature are pretty well convinced that this is nearing settled science. But there are many who don't follow the literature and just interact with it on a casual basis that are still quite skeptical. After all, nuts are a high-fat, energy-dense food, and for a very long time were viewed as problematic for inclusion in the diet, especially in an environment where overweight and obesity are public health problems. So let me go on to share some of the evidence base with you to substantiate the overview that I just provided. So to begin, we'll focus on the effects of nut consumption on body weight and adiposity. I'm not a great fan of meta-analyses. I think they have their limitations, but they are a very useful way to summarize large amounts of data. And that's what's shown here. This is a meta-analysis looking at trials that had body weight as the outcome of their assessment. And as you can see in the panel A on the left, down at the bottom, that triangle does not vary from 0. And what that means is that across all of these studies, there's no evidence that the inclusion of nuts in trials where they were offered without any other dietary guidance, that they alter body weight. And in panel B, the figure on the right-hand side, these are trials where there was a specific recommendation that the nuts should displace something else in the diet, for example, carbohydrate. And once again, shows that there is no effect of that kind of substitution on body weight. Similarly, this same analysis explored the effects on body mass index and found no effect in free feeding studies or in substitution studies. And the same finding for waist circumference. No effect of the inclusion of nuts in the diet in free feeding individuals or where there was a substitution protocol in place for waist circumference. And for percent body fat, no effect in free feeding studies. And there was actually a very small but statistically significant benefit in the trials that used a substitution paradigm. That is, people had a slightly lower percent body fat in those protocols. And this observation holds across different types of nuts. The strongest evidence base is available for almonds and walnuts, as shown here. And what it shows, again, in a different meta-analysis now, no effect of almond consumption or other types of nuts on body weight. So a very robust evidence base indicating that nuts can be included in the diet without provoking weight gain. Nevertheless, the 2015-2020 Dietary Guidelines mentioned quite explicitly that because nuts are high in calories, they should be eaten in small portions. It's an interesting statement because for no other food group was this kind of warning included in the guidelines. It was only for nuts. I should point out that the most recent 2020 guidelines did not review nuts in as great a detail as the 2015 guidelines, but the 2020 guidelines do not contain this same restriction. But it's an important point because many people still subscribe to that view, even though there are other foods that have an even higher energy density, for example, oil that we include in our diets. And there the statement in the 2015 guidelines was that the amount consumed should be within 1 AMPR for total fats without exceeding calorie limits. So a much more sort of moderate and positive view about the inclusion of oils compared to how the position was stated for nuts. And this was in contrast to that very substantial evidence base that I just reviewed for you. And additional evidence that this message is not getting out This was a survey conducted with dietitians, with general practitioners, and with practicing nurses. So people in the healthcare community that are interacting with both healthy individuals and patients and providing dietary guidance. In all three of these groups of practitioners, over half felt that nuts would lead people to gain weight if they were included into the diet. The question posed to them was, eating them will cause people to gain weight, and as you can see in the three categories of strongly agree, and neither agree or disagree, over 50% in each of those groups of practitioners apparently were not convinced by the evidence that I just shared with you. So one of the reasons that there may still be skepticism is that it's difficult to understand by what mechanism these energy-dense foods are not problematic when they're included in the diet. And over the last 2 decades, there have been a very sizable number of studies that have explored mechanisms to account for this. And I think we're at a point now where we recognize there are probably 3 components to the mechanism. And the first is that nuts have a very strong satiety value, satiation and satiety value. And as a result, they lead to strong dietary compensation. And by that, I mean that when nuts are included into the diet, people spontaneously adjust what they're eating at other times of the day to offset a good portion of the energy that was contributed by the almonds. This horrid slide is not intended for you to read in any detail, but to convey to you that there have been a substantive number of trials exploring compensation to nut consumption. And in the column second in from the right, that's the findings about compensation. And where it's green, it indicates that there was a very strong compensatory response. Yellow is no response, and red is where the response was very small. But you can see in the overwhelming majority of trials, compensation was strong. Interestingly enough, if you look on the column on the far right, that's the change in total energy intake. And there, it's not a perfect match with compensation. That is, people are either not compensating strongly for the nuts, or in fact, they end up in positive energy balance when they're included in the diet. And those were the clinical trials. In epidemiologic studies, you can see again, compensation is present in the majority of trials, but people still end up in positive energy balance. That compensation is not 100%, but it is moving in the right direction. And here's another meta-analysis that was published just recently that shows that, in fact, the evidence indicates there is a positive energy balance frequently observed when people are including nuts into their diet. So how is it possible that people are in positive energy balance but not gaining weight? So part of it is this compensation, and it accounts for somewhere in the 70–75% of the energy contributed by almonds range. But there is now emerging evidence showing that we don't absorb the energy from nuts as efficiently as one might expect based on the nutrition facts label on products, that we are relatively inefficient at absorbing and metabolizing that energy. So as we chew almonds, we include them in the diet, we chew them, they pass through our GI tract where they're hit with gastric acid and digestive enzymes. They reach the colon and are attacked as well by the microbiota there. There are a whole series of reactions that are designed to mechanically and chemically decompose the foods, the nuts that are consumed to extract the energy from them. However, the efficiency of that process is not the same as one would see if the nut was actually put in a bomb calorimeter and combusted there, oxidized there, to see how much energy is actually contained. Humans are just not as efficient as the instruments that we use to measure foodstuffs. And that's what's shown here, that there is a loss of energy from nuts in the stool, as well as a loss of energy in the form of fat in the stool when nuts are included in the diet. That's what all of the green boxes, all the studies that showed that we were not efficient at extracting all of the energy out of the nut, and so some of it was lost in the stool. We've done some modeling studies where we tried to simulate conditions in the stomach and in the intestine to see what's happening with the cells of nuts. And what's shown here is that there are intact cells in what would be the duodenal stage of digestion for walnuts, almonds, and pistachios. These are the greenish clusters, round clusters. These are cells of the nuts that have remained intact despite the digestive processes in the small intestine. And this is a micrograph from Peter Ellis's group of almond tissue that has passed entirely through a human volunteer. And as you can see, many intact cells. And so the lipid that are contained in these cells have passed entirely through this person and was not absorbed and made available to that individual. And the evidence now is suggesting that somewhere between 5 and 20% of the energy from nuts is not extracted as the nuts pass through the GI tract, that they are resistant. We don't chew them especially well, and they're resistant to microbial and enzymatic degradation. And as a result, a fair amount of the energy from nuts is lost. So that is part of the story contributing to why we can predict that people are in positive energy balance based on the nutrient label, but they're not gaining weight because we're not fully accessing the energy that the nuts contain. But there is a third part of the explanation, and that is that chronic nut consumption, regular daily consumption, may elevate resting energy expenditure somewhat and burn more energy. This has been observed in several clinical trials. This happens to be a trial with peanuts, showing that resting energy expenditure was elevated by about 11% with chronic nut consumption. And in that, resting energy expenditure accounts for something on the order of 70% of total daily energy expenditure. This increment of 11% is not trivial. Another trial has also observed an increment in resting energy expenditure, though only in individuals with obesity, not in people of normal weight. But again, it was on the order of about 11%. Now, when you put all of these three mechanisms together, the high satiety value, the lack of efficiency of energy extraction, and the elevation of resting energy expenditure, and this is done in a metabolic study, which we completed a few years ago now, what you can see is that we found 74% of the energy from the almonds, which we used in this trial, was offset by dietary compensation. About 77% was offset by inefficient extraction of energy, and 14% was due to an elevation of resting energy expenditure. And when you sum those together, it accounts for about 95% or so of the energy from the almonds. And so collectively, you can now understand how the epidemiology showed that there's no effect on body weight, and the clinical trials show there's no effect on body weight because these three mechanisms combine to offset the energy that the almonds are providing. So I think there is now a very credible evidence base for supporting the view that almonds can and other nuts can be included in the diet without exacerbating weight gain. With respect to diet quality, as I mentioned, there are findings that nut consumers have higher healthy eating index scores than non-consumers. In all fairness, it doesn't put people into a very high category, but you can see in both children, in adolescents, and in adults, the HEI scores are higher in nut consumers compared to non-consumers. Now, with respect to diet quality, I do want to make another very, I think, important point. Both the 2015 Dietary Guidelines and the 2020 Dietary Guidelines made a point of saying that if one is going to eat nuts and seeds, that they should be unsalted. Hypertension is a problem, and sodium has been linked to the onset and manifestations of high blood pressure. And so there is an emphasis on moderating sodium intake. And nuts are frequently consumed as a snack, and as a result, and are frequently consumed in a salted form. And so the guidance is to be cautious of that. But let me point out that the top 10 sources of sodium in the US diet are listed here. And even among the savory snacks, nuts are not included. They're in a different category. So nuts are not in the top 10 sources of sodium in the US diet. And of course, intake is a function of both quantity and frequency of consumption. And the frequency of consumption of nuts is not high. In this sample from NCHS, so a nationally representative survey of the US population, 60% of individuals don't consume on a given day, and 85 to 90% consume less than an ounce and a half a day. So the portion size and the frequency are very low. As a result, any sodium that would be contributed would be quite trivial. Additionally, there is a very kind of intuitive but not well appreciated point that even if we like salt and saltiness, it's not that we want to put as much of it as we possibly can on every food that we eat to get that sensation. We learn an appropriate amount on a given food and what makes it most palatable. So this is a trial done by Gary Beecham some time ago now, putting people on reduced sodium diets, but allowing them free use of the salt shaker for cooking and adding salt at the table. And what you can see is that they were on a reduced sodium diet, so total sodium intake was markedly reduced, but the amount added back, the black bar portion of this figure, was small and did not bring people back up to their baseline sodium intake. And we've done work showing that you can reduce a quarter to a half of the amount of sodium on foods without people really objecting to a loss in sensory function. And that's because when sodium is on the surface of a food, it has very ready access to salt receptors and gives a large sensory impact despite being a relatively low dose. And that would be the case with nuts. They're not naturally high in sodium, but the salt that's added to the surface is not there in high quantity, and we don't consume a lot of nuts. And as a result, they really are a trivial source of sodium in the diet. And you know, if one uses this logic of restricting the accessibility or the advisability of consuming a nutrient-dense food because it may have some other sensory property that would be of concern, then we'd be in a position of saying that we shouldn't promote milk consumption because some people add sugar to it, or it's added to sweetened cereals, or we shouldn't eat vegetables because some people put salt on them, or sources of saturated fat, or we shouldn't eat whole grains because they may be consumed in conjunction with processed meats, for example, I think we have to look at the total diet to determine what is a healthful or unhealthful use of individual foods and seasonings. Next, I do want to comment also on another, what I think is a fairly unique property of nuts, and that is the resistance to monotony effects. You all may well appreciate that if one is put on a highly monotonous diet, it may result in short-term weight loss, and it's primarily due to the fact that people spontaneously choose to eat less because food just isn't palatable. It isn't appealing to them. We have an inherent drive to seek variety and sensory stimulation, and monotony competes with that, and it proves to be the undoing of many popular diets. But there are some foods that seem resistant to this. So people, for example, are willing to eat bread on a daily basis or drink milk on a daily basis. And our observation is that nuts may have this same attribute. When we put people on research protocols and having them consume nuts on a daily basis for example, in this case, 12 weeks, and these are not people that were regular nut consumers prior to the trial, we see that they're inherently pleasant. They're rated pretty highly. But the important point is that they don't decline in any meaningful way with daily consumption over 12 weeks. This was a study where different seasonings were used. Here's a trial with almonds. So on a scale of 0 to 100 on palatability, they started off at about a 75. But after 12 weeks of daily use, they were still at a rating of 70. So they seem to be resistant to this monotony effect. And if one is then going to recommend that nut consumption be increased, which is recommended in the 2020 Dietary Guidelines, then this is a good sign because people can incorporate them in without finding them objectionable. And they can help with weight loss in individuals that are on energy restricted diets. The liberalization of the diet by including nuts can actually improve palatability and, as a result, adherence to the diet. And of course, diets only work if one sticks to them. And that's what's shown here in this study by Michelle Wien, that when nuts were added to the diet, weight loss was actually greater because people were more compliant. And a more recent trial by Gary Foster showed that after 18 months, those that were allowed to include almonds in the diet, their sustained weight loss was no different from the group that was not allowed to consume nuts. And finally, we are coming to the evidence for a really new observation with respect to nuts, and that is their specific effect on truncal fat depots. So here's one of the early trials showing that abdominal fat mass and total abdominal mass, as well as waist circumference, were lower in individuals consuming almonds on a regular basis compared to a control group. So an indication that a regular consumption would specifically tend to reduce this abdominal fat depot. And subsequent work by Japna Dillon showed that an almond-enriched diet led to greater reductions in truncal fat and an increment actually in lean mass in the almond consumers compared to those not consuming almonds. And that brings us to the most recent findings, work conducted by Dr. Hunter, and she will pick up the story from there. Dr. Hunter?
All right, thank you. So I'm going to be talking about a recent study Dr. Mattis and I did, assessing whether body fat distribution alters the metabolic response to chronic almond consumption. So epidemiological studies indicate that there is a decreased risk of type 2 diabetes with increased nut consumption, especially in women. This is data from the Nurses' Health Study, where women who consumed nuts more than 5 times per week had a significantly reduced risk for type 2 diabetes compared to women who never or almost never consumed nuts. And this was significant even after multiple covariate factors were adjusted for. Almond consumption, which is shown by the darker colored bars in this figure, improves postprandial glycemic response in acute trials compared to a control group that does not consume almonds, which is the lighter color bars in this figure, especially when almonds are consumed with breakfast, which is shown in the blue bars here, or as snacks, which is shown by the red bars and the orange bars. However, there is mixed evidence on the effects of almond consumption on hemoglobin A1C in long-term clinical trials. So hemoglobin A1C is a clinically important endpoint to address because it's a long-term indicator of blood glucose levels, and it is also used to monitor, diagnose, and treat type 2 diabetes. So previous studies have found that almond consumption reduces hemoglobin A1C compared to a diet without almonds in adults with type 2 diabetes. Other studies have found no difference between a diet that contains almonds and a diet without almonds in hemoglobin A1C. And other studies have found that a controlled diet without almonds reduced hemoglobin A1C more than a diet with almonds in adults with prediabetes. So we thought that one of the reasons for this mixed evidence of almond consumption on hemoglobin A1C stems from testing people who have different body fat distributions, who carry different risks for insulin resistance and type 2 diabetes. So the first type of body fat distribution is having a large android visceral adipose tissue, which I'll abbreviate VAT. This type of fat depot is most strongly associated with insulin resistance and type 2 diabetes. So this is a cross-section of the abdomen, and at the top of it is where the belly button would be, so that's the front side of the body. And then towards the bottom, there is the vertebral column and the spinal cord. So towards the bottom of the figure is the back side of the body, just to orient you with this figure. So the pink squiggly tissue is the abdominal muscle, and then the tan tissue is the visceral fat. So the visceral fat is located within the abdominal cavity, and it surrounds all of the internal organs. So one of the reasons it's most strongly associated with insulin resistance and type 2 diabetes is because of this location within the abdominal cavity. So it surrounds all of the internal organs, and anything the visceral fat secretes drains directly to the liver because it's connected to the portal vein. This is especially problematic because visceral fat also has reduced expression of anti-lipolytic receptors, most notably the insulin receptor, and has increased expression of lipolytic receptors. So its rate of lipolysis is less controlled, especially after a meal, because it's not responding to insulin as well. And then its location and rate of lipolysis combined make it problematic because it contributes to a high hepatic lipid content and high VLDL production, which all contribute to a state of insulin resistance. The second type of body fat distribution is having large amounts of android subcutaneous adipose tissue, which I'll abbreviate SAT. So this type of fat is also located in the midsection. So this figure is the same cross-section of the abdomen that I showed you before, but the subcutaneous fat is the darker tan tissue here. So the subcutaneous fat is less problematic for metabolic disease compared to visceral fat, in part due to its location. So whereas visceral fat was within the abdominal cavity, subcutaneous fat is on the outside of the abdominal muscle and is directly underneath the skin. So because of its location, anything the subcutaneous fat secretes drains to the systemic circulation, so it does not put as much of a burden on the liver like visceral fat does. Subcutaneous fat is also less problematic compared to visceral fat because it is more responsive to the anti-lipolytic effect of insulin, so its release of free fatty acid is more controlled, especially after a meal. However, subcutaneous fat may still carry some metabolic risks and risks for insulin resistance because it has the ability to expand much larger than visceral fat does. So subcutaneous fat, if it expands much larger, it would have more adipocytes that can contribute more free fatty acids to circulation, which can contribute to a state of insulin resistance. And then the third type of body fat distribution is having a large glutofemoral adipose tissue. And this type of fat is located around the hips and thighs, as opposed to the android or midsection like those other two body fat depots were. So glutofemoral adipose tissue is not associated with insulin resistance or type 2 diabetes, partly because of its location. So like subcutaneous adipose tissue, it also drains to systemic circulation and does not put any burden on the liver. But glutofemoral adipose tissue also just has a low free fatty acid flux, and it's considered an energy sink, meaning that rather than contributing a lot of free fatty acids to circulation, it takes them up and stores them as triglycerides until they are needed during periods of prolonged energy deficit. So because of these differences in body fat depots and their risks for insulin resistance and type 2 diabetes, we wanted to see if this accounted for that mixed evidence of almond consumption on hemoglobin A1C. So we conducted a 6-month randomized controlled trials in 134 participants whose BMI was greater than 27. And then we recruited participants following into one of 3 different body fat distributions. So the first group having high android visceral fat, the most problematic type of fat for insulin resistance and type 2 diabetes, the second group having high android subcutaneous fat, and the third group having the high glutofemoral fat, which is not associated with insulin resistance or type 2 diabetes. And we determined their body fat distribution using a combination of waist to hip circumference ratio and information from a DEXA scan. Within each body fat distribution group, we randomized participants to either the control group or the almond group. Participants in the almond group consumed 42.5 grams of almonds every day throughout the 6-month intervention, half of that with their breakfast and half of that as their afternoon snack every day. And this was equivalent to about 2 small handfuls of almonds every day, shown in the figure in the top right. And then participants in the almonds were not allowed to consume any other nuts or nut products besides the almonds that we provided them. And then participants in the control group continued their habitual breakfast and afternoon snack routines, but were not allowed to consume any other nuts or nut products throughout the 6-month intervention. And I do want to note that we recruited participants who consumed an afternoon snack of low nutrient density. So this allowed us to compare almonds as a snack compared to a typical snack that is of low nutrient density. So first, we hypothesized that almond consumption would reduce hemoglobin A1C in those with high visceral adipose tissue, which is most strongly associated with insulin resistance and type 2 diabetes, that almond consumption would have an intermediate effect on hemoglobin A1C in those with high subcutaneous adipose tissue, and that almond consumption would have a limited effect on hemoglobin A1C in those with high glutofemoral adipose tissue. And we assessed hemoglobin A1C through blood samples that we collected at baseline and after the 6-month intervention. So after the 6-month study, we did not find any difference in hemoglobin A1C between the control group, which is shown by the white bars, or the almond group, shown by the black bars, for any body fat distribution cohort. However, I do want to point out that all of our participants had a baseline hemoglobin A1C less than 5.7%, which is considered normal. So it could be that there was limited capacity for hemoglobin A1C to decline in our participants. Next, we hypothesized that substitution of almonds for other common snacks would not promote weight gain, as the rest of the literature suggests. And after the 6-month intervention, we found no significant difference in body weight between the control group and the almond group for any body fat distribution cohort. This was true even though participants in the almond group consumed about 200 calories per day more than the control group. So our results support the rest of the literature that almonds, despite being a high-fat food, do not contribute to weight gain. And then lastly, we hypothesized that almond consumption will improve body composition compared to the control group. And we assessed body composition using a DEXA scan that we collected at 0 and 6 months. And first, we looked at the total fat and lean mass percentages. So there was no significant difference between the control group or the almond group in total fat mass percentage shown on the bottom, or total lean mass percentage for any body fat distribution cohort. Next, we look specifically in the abdominal or the android region, which is where those two more problematic fat distributions were, the visceral fat and the subcutaneous fat. And we found that the almond group significantly reduced android fat mass percentage compared to participants in the control group and those with high subcutaneous adipose tissue, and almond consumption significantly increased android lean mass percentage compared to participants in the control group and those with high subcutaneous adipose tissue. But there were no differences between android fat or lean mass percentages between the almond or control group in participants with high visceral adipose tissue or high glutafemoral adipose tissue. So then next we looked at the composition of that fat within the android region, so looking specifically at the visceral fat mass and the subcutaneous fat mass. And we found that almond consumption attenuated a gain in visceral adipose tissue mass in those with high subcutaneous adipose tissue. So in those with high SAT that consumed almonds for the 6-month intervention, they very slightly reduced their VAT mass, but the difference was largely due to the control group gaining a lot of VAT mass. But then there were no differences between in SAT mass between the almond group or the control group, between any body fat distribution cohort. And there were also no differences in VAT mass between the almond or control group in those with high VAT or high glutafemoral adipose tissue. So in summary, body fat distributions did not explain the mixed evidence on almond consumption and hemoglobin A1C like we hypothesized. However, future directions should assess the effects of body fat distribution with almond consumption and hemoglobin A1C in participants who have elevated hemoglobin A1C levels at baseline. So we recruited participants who had a BMI greater than 27 that fell within one of the 3 body fat distributions. However, in participants who have elevated hemoglobin A1Cs, this would help to better address the discrepancies in the literature, especially since all the previous studies that have assessed almond consumption and hemoglobin A1C were done in adults with type 2 diabetes or prediabetes. And then we also found that substitution of almonds for other common snacks did not promote weight gain despite higher energy intake, which supports the rest of the literature. And then lastly, that almond consumption improved android fat and lean mass percentages in those who had high subcutaneous adipose tissue, which also supports the rest of the literature that almond consumption may be beneficial at reducing truncal fat mass percentage. So with that, I'd just like to acknowledge the research team from both Purdue University and IU School of Medicine, where we conducted this research. Most notably, my advisor and the previous speaker, Dr. Mattis, and then Dr. Bob Constantine, who led the team at IU School of Medicine. And of course, the Almond Board of California was our funding source, so I'd like to acknowledge them as well.
So with that, we hope you enjoyed the presentations, and we'd like to welcome you to the Q&A session. First off, I think we'd like to look at the poll results from the poll we took at the very beginning of the presentations. So if we could have those up, looking at them, if we see a lot of you folks actually responded with D. Looks like that's majority of our responses. So there was quite a bit of understanding and knowledge about almond health benefits, and we really do hope that these presentations have helped to improve those scores to a higher number on that scale. So with that, we'll go ahead and get started and look at some of the questions that are coming into our Q&A box. And I would also like to encourage you to continue to post your questions there. To start out with, I think the first question could be addressed to Dr. Mattis. Dr. Mattis, do you think that metabolizable calorie estimations could be on food labeling or should be on food labeling?
All right, that's a very, very interesting question and no clear answer there. There's no question that it's beneficial to have energy value on package so consumers have some idea of the consequences of what they're eating. So that's a given. But we all have to take a closer look at how those labels are interpreted. Right now, they are a specific number, and people tend to view that number as a hard and fast, invariant characteristic of a food. If something says it has 100 calories, everyone assumes it is exactly 100 calories, and that's just not the case. For any food, the ingredients are sourced from different plants that are grown under different climates and different soils. They're processed differently. All of those things influence the actual energy value. And so that number has more noise or variability to it than the label would indicate. Now, with our newer techniques and understanding, we're recognizing that there's another source of variance in this equation, and that is the degree to which individuals extract energy from their foods. And nuts have become a sort of the poster child of this issue because very consistently now the evidence indicates that we are relatively inefficient at extracting that energy. And so the question has become, should we alter those labels knowing that somewhere between 5 and 20% of the energy from nuts is not going to be bioaccessible? And reasonable people can come to different conclusions on that point. I think that, again, we have to recognize there's going to be marked individual variability in this human contribution of variance. Some of us chew foods more thoroughly than others, and the form in which we consume the nut, for example, if it's added into a yogurt, well, that yogurt adds a certain amount of lubricity. And keep in mind, the primary purpose of the oral phase of digestion is to mechanically reduce a food to a point where it can be formed into a bolus and swallowed safely. Avoidance of choking is a primary driver here. So if you consume nuts with something that adds lubricity, makes it easier to swallow, then we tend to swallow larger pieces of it. And so those larger pieces would translate into a lesser efficiency of absorption. So it's a very complicated story. My guess is that there won't be strong enthusiasm to modify the food label, despite our knowledge that there's probably less energy in a nut than expected, just because there's still a lot of variance associated with that number.
Thank you, Dr. Mattis. I think that's a great answer to that question. I might just add, for the benefit of our audience and for those who might be interested, that USDA Food Data Central now does feature the metabolizable energy values for foods that have had them measured, and these can be found under the experimental tab for any given food. So with that, I think we have another question here, and the next question is probably best for Dr. Hunter. Dr. Hunter, why do you think there was an improvement in android fat and lean mass percentage in those with high subcutaneous adipose tissue, as opposed to visceral adipose tissue related to almond consumption? Sorry, we're unable to hear you. Oh, Houston, we have a problem. All right.
Dr. Hunter, try on where it says mute, the drop down, the little arrow. Click on that one and choose the correct microphone. Or click on switch audio and dial in to WebEx. And maybe, Swati, you can ask another question to
Sure.
to
Yeah,
Dr.
we
Matt.
do have another question for Dr. Mattis. So, Dr. Mattis, we know that insulin resistance and body fat, they seem to go hand in hand. And it's really exciting to see the study demonstrate a significant decrease in fat mass percentage. And I think it's very intuitive for a lot of people to associate a decrease in fat mass percentage with improvement in health parameters. But we also see preservation of lean mass percentage. And for the benefit of our audience, if you could speak a little bit to why that might be important as well, that would be great.
Yeah, that's important for a couple of reasons. One, lean mass is, of course, metabolically more active than fat mass. And so in terms of the energy balance equation, maintaining a higher lean body mass would improve energy balance. We would be burning more energy to support that body compartment. But it's also functionally important. When we're talking about the health of an individual, we're also taking into consideration their ability to engage in daily activities and across the lifespan. And so maintaining a good lean body mass helps with strength.
9, 4, 6, 8.
Helps with strength and with balance, and so particularly in individuals that are at the upper end of the lifespan, those are very important dimensions to pay attention to.
Yeah, makes a lot of good sense. So thank you for explaining that. I'm not sure if Dr. Hunter's microphone's working. Do we want to give it a quick check here? Can you hear us, Stephanie? Okay, so it looks like we're probably still experiencing some technical issues there. So perhaps I'll go ahead and ask the same question I asked of Stephanie to you, Dr. Mattis. Why would you think there was an improvement in android fat and lean mass percentage in those with subcutaneous adipose tissue as opposed to visceral adipose tissue in this study?
Well, I should point out that statistics are indicators. They help us make decisions and they help clarify our thinking, but we shouldn't be slaves to specific numbers. And in the trial that Steph reported on, there was a clear trend for a reduction in visceral adipose tissue as well. It just did not reach our a priori criteria significance. So, subcutaneous hit that level, visceral didn't quite make it there, but they were both moving in the same direction. And it just may be that there is a larger body of subcutaneous tissue, and so the turnover is greater, and that gives us more variance to work with statistically to find effects.
Right. Yeah, I think I should point out, and please correct me if I'm wrong, but one of your previous studies with Japna Dillon did show a significant decrease in the visceral adipose tissue mass. So what you're really saying is it depends on the variance and the statistics of a given study and the subject recruitment that happens, because it's not something we can control in any given study. Would that be correct to say?
Yeah, I think that's an accurate statement, and the reality is there are relatively few studies looking at this outcome so far, and so we don't want to overemphasize the findings from a single study. As the evidence base grows, my guess, and obviously I can be wrong, but my guess is that we'll find that there are benefits in both of those depots.
Okay, thank you. Stephanie, are you able to hear us?
I think she can hear us, but we can't hear her.
We still can't hear you. I'm so sorry.
I think we can.
guess...
Can you speak into the yeah?
Can you hear me now?
Yeah, thank you.
Okay. Sorry about that.
Oh, no problem. It's great to have you with us. So thank you. I guess one of the questions I got that you could potentially answer is what are some resources to actually help classify body fat distribution?
Gosh.
Sorry.
Yeah, there we go. Unmute
What
your phone.
about now?
Yeah.
Oh,
Yeah.
yeah, there we go. Perfect.
Okay. Okay, so we use DEXA scan to classify our participants. That is like some technology you might have to like go to a doctor's office for and pay a bit for. But it does give a better understanding of especially differentiating visceral adipose tissue from subcutaneous adipose tissue. But a simple way just to kind of like understand body composition with health is you could do waist circumference. So that could give you a good indication of just like how much like central adiposity there is. Of course, you can't tell the difference between visceral adipose fat and subcutaneous adipose fat that way. But of course, reducing waist circumference on its own would also be beneficial.
Right. Thank you. We have also heard of bioelectrical impedance as an assessment method. How would you compare that, excuse me, to DEXA?
Yeah, I think DEXA is a little bit more accurate than that. You could also do like an MRI, which would be better than a DEXA as well. But of course, there's like cost trade-offs and with that as well.
Wonderful. Thank you so much. And this question is for either one of you, so whoever, maybe both of you want to take a jab at it, but there is a lot of almond-related glycemic response or regulation research that is published already. And I think Dr. Mattis particularly is very familiar with all of the background in that field. Looking at the totality of evidence, what would you say is really the role of almonds? Is there possibility to shed light on what the potential mechanism of action behind the role of almonds might be in glycemic regulation? Dr. Mattis, would you like to start out with that?
Okay, yeah, I'll take a first stab at it. Yeah, so there's two levels of consideration here. First is the acute glycemic response following a meal, the postprandial. And because almonds are a rich source of fat and of fiber, they're going to slow the absorption of glucose from the gastrointestinal tract. And if it's absorbed more slowly, then the liver can better regulate blood sugar levels, and so it's going to moderate swings in blood sugar. So acutely, I think we're probably pretty confident that that mechanism will apply. But the real goal for blood sugar management is a chronic outcome, and that's referenced by hemoglobin A1C. And as you referenced in your introduction, Dr. Kelligorn, there is evidence that there is a reduction in hemoglobin A1C in several trials. Now, it's not in all trials, but in those that don't find it, they're often short-term, and the half-life of a red blood cell is about 30 days. So unless one conducts a trial of adequate length, you're just not going to see, you're not going to be able to accurately measure that outcome. So many trials are just not designed properly to measure it. Those that are longer term have a better chance. And as Steph pointed out, if you start with a healthy population, people with normal hemoglobin A1C, it's very hard to improve on normal. And it's not even necessarily a goal, a medical goal. But in participants that have elevated baseline hemoglobin A1C that are of sufficient duration, there we see a more consistent effect. It still has to be confirmed with additional studies, but I think there's an indication that there really is a phenomenon that is important there.
Thank you. Dr. Stephanie Hunter, would you like to take a stab at it too?
Yeah, can you repeat the question one more time? Sorry.
Yeah, no, I was just saying, looking at the totality of evidence in terms of almonds and glycemic regulation or glycemic health, what role do you see almonds playing in terms of the potential mechanism of action?
Yeah, yeah. So yeah, going off what Dr. Mattis said, also the monounsaturated fatty acid content of almonds can also help improve glycemia. So it's also interesting. So like there's a lot of evidence that show that almonds can improve like postprandial glycemia. And this postprandial glycemia also like is a strong contributor to hemoglobin A1C. So it would be interesting to get these more studies done in participants who have the elevated hemoglobin A1C. And just confirm how almonds can help reduce that, especially since we also see the epidemiological studies that show that nuts can help reduce type 2 diabetes. So yeah, it all kind of fits into reducing the glycemic response there.
Thank you. And just for the benefit of our audience, I did want to mention that we have some studies that are ongoing in one of the more challenging populations when we talk about diabetes, which is the Southeast Asian phenotype, that does tend to be more inclined to getting type 2 diabetes at a much lower BMI. And so we'd like to request you to please stay tuned for results from those, and we'd be happy to share them with you as and when they come out. I see that we're actually getting close to the end of our session. So although we have a couple more questions in the chat here, we'll go ahead and send responses to those individually. We'd like to thank you all very, very much for joining us today. And I'd especially like to thank our speakers, Dr. Mattis and Dr. Hunter, for presenting today. Thank you all very much and have a wonderful day.